everyone, and a warm welcome to you all to the second OncoConnect Global Summit hosted by MedSynapse. Our primary focus is to advance oncology through collaborative efforts. MedSynapse is a neutral, peer-to-peer professional medical network dedicated to expanding the horizons of healthcare professionals through real-time knowledge sharing, with the aim of creating a platform that doctors love to use for solving complex clinical problems. At MedSynapse, we provide healthcare professionals with seamless, fast, simple, and secure solutions that facilitate clinical collaborations. The second OncoConnect Global Summit stands as a testament to our commitment in this regard. We have the privilege of bringing together experts from around the world, all dedicated to sharing their invaluable knowledge with our community. For our session today, we have with us Dr. Srikamakshi, who will be talking about the applications of lasers in head and neck cancer management. Dr. Srikamakshi is currently a consultant head and neck oncologist at Karkinos Healthcare, Hyderabad. She possesses clinical expertise in identifying and diagnosing pre-malignant and malignant lesions in the head and neck regions of the body. Her dedication extends to performing high-quality surgeries in terms of skills and safety in operating room and field. It's wonderful having you with us, Dr. Srikamakshi, and thank you for taking time out to share your thoughts and inputs with MedSynapse medical community. And to our audience, remember to share your questions for Dr. Srikamakshi in the comment section. We will try and address all of them at the end of the session. Without any further delay, let's dive right in. Over to you, Dr. Srikamakshi.
Hello, Dr. Harshita. So happy to be here as part of the second OncoConnect Global Summit organized by MedSynapse. I feel it's a very interesting program that you've put together. You're bringing together oncologists across the globe using the virtual platform, which has become so popular in the post-COVID era, or so to say. But it makes it so much simpler and easier for doctors and oncologists specifically in this particular program to be able to collaborate with each other, learn from each other. So generally, these conferences happen at a particular place, and all of us have to, go there and assemble there. Over the next few days, we do learn a lot of things. But when it becomes virtual, it becomes so much simpler and easier for busy doctors, to participate in it, and everyone benefits from it. And ultimately, it's the patients who are going to benefit even more. So very happy and glad to be here. Good evening, everyone. I welcome all of you, and I hope you are able to understand a few things about the application of lasers in the management of head and neck cancers over the next 30 odd minutes. Okay, so let's dive right in. So over the next 45 odd slides, I will be taking you through the application of lasers in the management of head and neck cancers. So I'll just give you an overview of what this presentation is going to be. We will initially try to understand what exactly a laser is. We will then look at the different types of lasers which are commonly used in medical practice. We will then look at the specific application of lasers in the management of oral cavity lesions and in the management of lesions in cancer of the laryngeal region. Okay. So what is laser? Laser is an acronym which stands for light amplification by stimulated emission of radiation. So this is a device which is going to emit a light which has been amplified optically from the stimulated emission of electromagnetic radiation. So in the next slide, you will be able to understand this a little better. So the end result is that the light which is produced by a laser is coherent, which is what makes it different and unique from the regular LED light and other lights that we see. So what is coherence? Coherence means that all the light rays are of the same wavelength and same frequency, and they are synchronized with each other. Now, the laser light has two types of coherence. It has spatial coherence and temporal coherence. Spatial coherence is what allows it to be focused into a sharp pencil tip type of beam, and this allows for cutting using laser and lithography, and this focused light remains focused over long distances. This is called collimation, and this is how we have our laser pointers. The other property is temporal coherence, is again because the light gets emitted over a very narrow spectrum, and you can produce extremely short pulses, as short as a femtosecond. Okay, so on the left is an image which shows you the difference between a laser light which is coherent and the normal light that we see in our day-to-day lives, which is incoherent. And on the right side is a very simplified imagery of how a laser system works. Okay, let me try to explain it to you as simply as I can. So the box is called an optical resonator cavity, and in the middle what you see in red is called the gain medium or the amplification medium. So if we take the example of the carbon dioxide laser, this gain medium is usually carbon dioxide plus nitrogen plus helium. Okay, so what happens is some form of energy is supplied to the laser, usually electrical energy, and this excites the nitrogen ions first in the CO2 laser. This nitrogen ion goes to an excited state. Why do we use nitrogen? It is believed to be stable, relatively stable at that excited state, such that it can transfer its energy to its nearby carbon dioxide atom, which in turn gets excited. And as it comes back to its ground state, this energy is what contributes to the laser energy. Okay, and this process continues, and this laser energy which is produced inside that cavity gets reflected and amplified like millions of times. So what you see at the left end of the box is a mirror which is completely opaque, and its only job is to reflect endlessly. And the mirror at the right side of the box is partially reflective, and it partially transmits the light out, and this is the laser beam that we see. Now this laser energy generally operates in the infrared region of the spectrum, so we cannot see it. Continuing with the example of the carbon dioxide laser, this is why we have the helium ions also. And the laser beam, the spot that you will see when you are operating the laser, it will be a red spot. This is actually the helium. Okay, so this is how, putting it very simply, a laser system works. So what are the widely used types of lasers in head and neck surgery? We have the carbon dioxide laser, as I just explained. We have the erbium yttrium aluminum garnet laser. We have the neodymium yttrium aluminum garnet laser. And you have the potassium titanium phosphate laser. So now each of these lasers is going to produce the laser beam at a different wavelength. And depending on that wavelength, the interaction with the biological tissue that it comes into contact with is going to vary. Now, this light can be either absorbed or reflected completely or scattered by the biological tissue, again depending on the properties of that laser beam and the property of that biological tissue. So what are the advantages of using lasers in cancer surgery? One is remote application. Like for example, this carbon dioxide laser, when you use it for laryngeal surgery, although you also have the fiber which you can directly use in contact, there is something called the scanner or the micro manipulator which gets fixed to the microscope, and you will operate the carbon dioxide beam from outside, from through the microscope into the lesion which is sitting on your vocal cord. So it is minimally invasive. You are applying it remotely, and you're getting you are getting extremely good results. And the cutting which is done with the laser is very precise. You can gets cut off very sharply, like a scalpel, or even better than a scalpel. And the hemostasis with the laser is very good. In fact, there are lasers which are specifically used for just hemostasis. The scarring which results post a laser assisted surgery is very less. It's like a fraction when you compare to a surgery which is done using a scalpel or even using your electrocautery. The post-operative discomfort that the patient experiences with the laser surgery is again much lesser compared to any of the other modalities of surgery. And you can combine the laser with other technological equipment like the endoscope, the microscope, or even robotic surgery. So now the laser generally operates in two modes. One is the focused mode and the other is the defocused mode. In the focused mode, the energy gets concentrated on a very small region. It's very focused, of the size of 0.1 to 0.5 millimeter, and it can be used for like it can be used as a scalpel, and you can use it for making an incision, or you can clearly excise any tissue which you find suspicious. It is also used in the defocused mode when the size becomes slightly bigger. I mean, from 0.1 to 0.5, it becomes 1 to 5 millimeter. And this can be used to just superficially remove any precancerous or doubtful small areas that you see, which is very common in the oral cavity, because this oral cavity cancers have a tendency to to field cancerization, especially in tobacco users. You will find patients who will keep coming back. You would have operated on one side of the buccal mucosa, but they'll come back to you after a year on the contralateral buccal mucosa, again after 6 months on the palate, on the tongue. This is very commonly seen. So in such patients, if you can maintain a good follow-up and actually remove the precancerous lesions as they appear, where when they are very small itself, you will be contributing to improving the disease-free survival and in turn overall survival of the patient. So as I was describing, this is a very unique surgical procedure which is possible with the laser, where you can address any precancerous lesions in the oral cavity by just superficially taking it off. Okay, so let us look at some of the commonly used lasers in medical practice. We will start off with the carbon dioxide laser. This was invented by Kumar Patel in 1963. It is currently the most widely used and scientifically validated laser, especially for lesions of the oral cavity. Like I said, you can use it like a knife in the focused mode, just sharply remove tissues, or you can use it in the defocused mode for vaporization. Now, there is another interesting feature of the carbon dioxide laser, which seems to give it the property of preventing the dissemination of the cancer cells during treatment. Why you will and why this is important, you will understand as we proceed into the talk. Small sized artery veins, lymphatics of the size of 500 micrometers can be closed by the carbon dioxide laser by its action due to by the action of inducing contraction of the collagen in the walls of the vessels. Okay, so this carbon dioxide laser gets absorbed by water. So you will have like very minimal penetration, which means you have great control over the laser as you are applying it. You are cutting only what you see. You don't have to worry about it cutting tissues beneath it without your knowledge. And it is very effective in tissue removal. Now, this very precise and this minimal penetration makes it ideal for laryngeal surgery, because there is a lot of water content in the laryngeal tissue, and you want to very specifically remove only the lesion without causing too much collateral damage, because the larynx is a very small area but which performs very important functions of swallowing, breathing, and speaking, for which the whatever tissue we are able to leave behind is going to make a lot of difference. As you use the laser, the underlying muscle does not get stimulated much, and the inflammatory response which happens post laser surgery is very delayed, and it is very much reduced in intensity as compared to other modes of surgery. And so the patient is much less uncomfortable post treatment, and so because of this, you can use the laser for removal of at least lesions of the oral cavity as daycare procedures. Okay, so the next laser we will briefly discuss is the neodymium yttrium aluminum garnet laser. So basically the difference in these lasers, these terms, is primarily because of what material is used in that gain medium that I was talking about. Okay, so in this ND-YAG laser, this neodymium YAG crystal is the gain medium, which helps to amplify the energy. Okay, so this is going to emit light at a wavelength which is between the absorption of blood and water. So it will penetrate deeper than your carbon dioxide laser. So there is a risk of a larger area of effect or surrounding to where you wanted to actually target. But this also gives it the property of coagulation. So it is very useful in case of tumors or tissues where you're expecting hemorrhage. Okay, so many times it is used just for coagulation along with the other lasers or even with the knife assisted surgeries. So this the next is the erbium YAG laser. Erbium YAG remember dental procedures. This laser has a property of being able to cut soft tissue and hard tissue. For example, bone or your enamel and dentin in dental tissues. So this is absorbed by both water and hydroxyapatite. So it makes it highly suitable for dental procedures like your caries removal, root canal treatments. This was actually brought in as an alternate to drilling using the burr, the mechanical drilling. So when this was brought in, there was so much of a so much of a difference in terms of the pain and the vibration that you get with the burr for the patient. So the patient had like much less pain and it was more comfortable for them. And also it has an additional bactericidal effect. And like I was already saying, it can actually cut through bone like a burr, okay, or a drill. But it also has the added benefit that when it acts upon bone, the resulting inflammatory cell infiltration is much more pronounced, and the healing and the revascularization and the new bone formation happens much more quickly than when you would have used a mechanical burr or even the carbon dioxide laser. The last laser we will discuss is the potassium titanyl phosphate laser. This has a wavelength which is very much near the absorption maximum of hemoglobin. So again, it makes it highly effective for hemostasis. It can penetrate the water with minimal absorption or scattering. So again, it is used for coagulation of vascularized tissue. But what made it very popular was that it could be used as an office procedure for laryngeal lesions. It was seen to be effective on both vascular lesions like recurrent respiratory papillomatosis and dysplasia, where it would target its microcirculation. It was also effective in non-vascular, even benign lesions like just Reinke's edema or leukoplakia, where it would target the adjacent blood vessels. This particular target tissue or lesion may be avascular, it would target the adjacent blood vessels, and this would lead to regression of the lesion. So this KTP laser was actually brought in as an alternate to the pulse dye laser. This was the first laser which was developed for office procedures. There were two problems with the pulse dye laser. One was there was a lot of procedural bleeding because of the short pulse width of the laser, very short pulse width, and because the fiber was slightly larger. Now, so when you use a fiber laser, you have to pass it through the suction channel of the laryngoscope, the flexible laryngoscope that you use. And so this channel is the only working channel. You will have to use it for suction. You also have to use it for applying the laser. So it gets very difficult ergonomically to handle both. You get very clumsy. Even the suction will not work when you put the laser, also because it's just so big, it will not allow the suction to act properly. So it gets a little difficult. So this KTP laser was able to overcome both the shortcomings of the PDL laser because it had a larger pulse width, which means the energy would get distributed more uniformly over a longer period of time, resulting in effective intravascular coagulation via slower intraluminal heating. At the same time, there was the collateral injury like to the lamina propria was minimal. And also the size of the fiber of the KTP laser was less than half of the size of the PDL laser. So it was easier to handle it for doing office procedures. So what is important in handling any laser is you have to understand the workings of the laser. You have to understand the settings that you need to use for each laser. Okay, so for the KTP laser, you can set the power, you can set the pulse width, that is how many milliseconds you want it to act, and you can also control the frequency, how many pulses per second. So these settings can be varied according to the target tissue and what the surgeon prefers as well. Okay, so generally what is done is this KTP laser fiber will be placed about 2 to 4 millimeter above the target lesion. You fire it until the lesion blanches. Okay, if you want to remove the lesion, you can even place the fiber in contact with the lesion, and you can sort of excise it and remove it through the suction channel. So what can be the complications, any complications associated with a procedure done under local anesthesia? Because it's an office procedure, can happen, like vasovagal syncope or toxicity due to the local anesthetic agent. And you always have to remember that when you use laser, there is always a potential for laser injury. So you need to take all precautions. You need to use saline. You need to have only essential personnel in the room. You need to use protection glasses for the patient and for yourself and for the other staff. And you put a board outside the room saying that a laser procedure is in progress and don't enter unless you really have to. And since this is a office procedure, you should always be prepared that you may have to convert the procedure to a general anesthesia if the situation is not optimal. Okay, so now we have seen an overview of about laser. We have seen the different types of lasers. Let us come to its application in the management of head and neck lesions. First, we will talk about oral cancer and precancerous lesions. Okay, so the carbon dioxide laser is the current most popular laser in the management of oral lesions. So coming from an oral lesion or tumor perspective, generally when you do any procedure in the oral cavity, you have to think about reconstruction because the tissue is minimal and it plays a very important role, chewing, eating, speaking, etc. So you will always have to consider whether it needs reconstruction. The beauty of laser-assisted resection is that in most times it does not require reconstruction. The scarring is very minimal, so the functional outcomes can be expected to be optimal, and the recovery in terms of morphology and function following laser surgery is found to be superior as against cold steel or against electrocautery. Okay, and for the removal of precancerous lesions, laser-assisted excision and even vaporization has been seen to produce equivalent results compared to scalpel electrocautery or even cryosections. Okay, so when you have put a laser and removed a lesion in the oral cavity, you can just leave it exposed and allow it to granulate and allow it to just heal by secondary intention. You don't need to do any dressing, any skin graft, any flap. It will just mucosalize beautifully on its own. There are two interesting papers which came out regarding this. One was by Hares et al. In 2012, and in 2021, very recently, by Dr. Pratmesh Pai and his group at the Tata Memorial Hospital, where they did a comparative study between primary closure, as in with suturing on one hand and allowing it to just heal by secondary intention on the other hand, lesions of the tongue, which were resected in most cases using the carbon dioxide laser. And they found that functional outcomes in terms of tongue movement, the articulation of words was much better when you allowed it to heal by secondary intention than when you had actually sutured it. Okay. And see, when you do a laser excision, the healing is going to be slightly delayed, but the ultimate outcome, there's no overall effect. Now, because the collagen gets hit, as we were discussing with regard to something else, the vessels and arteries, the collagen gets reduced, and this is how the soft tissue movements is maintained. The tissue remains pliable. And in fact, there are authors who use it even for T1 and T2 oral cancer resection, similar to the TMH group. Some even use the microscope just to be sure. So when you do this, the pain control is much lesser. The post-op stay is much low. Okay, see, so now there are 2 points which we need to keep in mind with regard to the use of the carbon dioxide laser. One, there is some controversy in literature regarding that there is some thermal damage induced by the laser on the incision line, which can interfere with the assessment of margins, etc., in histopathology. See, what my experience has been is that when you use the carbon dioxide laser in the focused mode, when you have set the settings appropriately, when you're using it at the correct focal length, under the microscope, the cutting is very sharp. There is almost zero charring. But if you're using it in the defocused mode, when you have not focused it properly, that is when a lot of charring happens. It does not cut and it gets difficult. Okay, and laser-induced thermal injury is something you can never forget. You always have to be conscious about. And anything which is dry, dry gauze or a patty or even paper drapes will just get penetrated instantly by the laser. However, if you put saline all around and in the surroundings of the area which needs to be laserized, it cannot penetrate. Okay. Also remember that gloves can be penetrated, your endotracheal tubes can be penetrated. So what they generally do is they will put saline in the cuffs of the endotracheal tubes and put saline pads all around as far as possible. So these are photos of some patients whom the lesions I excised using the carbon dioxide laser. The first picture is actually a proliferative verrucous leukoplakia. The second picture is a sort of heterogeneous simple leukoplakia, which we just vaporized. And the third is an erythroplakia on the tongue. We have also excised any suspicious lesions. And during my short tenure at TMH, squamous cell carcinoma of the tongue was also excised using the carbon dioxide laser and allowed to heal by secondary intention. And I've seen the patients go home the very next day or maximum 2 days without any undue bleeding or discomfort that you would expect or you even see when a primary closure suturing is done following cutting with an electrocautery. So whatever patients who might use the carbon dioxide laser in the oral cavity, most of them was under local anesthesia. General anesthesia was used when this was done along with another surgery. Otherwise, when the procedure was just for removing laser-assisted excision of a lesion or vaporization of a lesion in the oral cavity, we've always done it under local anesthesia. There's never been any undue bleeding, like the patient had to be brought back into the room for hemostasis, never did any reconstruction. It mucosalized beautifully on its own. There is no scarring. The discomfort experienced by the patient is less. You just put him on some regular painkillers and you can send him home the same day. You can in fact repeat the procedure. I have done repetitive procedures on the same patient on adjacent tissue, opposite side, etc. Okay, so this was an interesting paper which I read as I was preparing for this talk, actually. So this paper was published in 2020 from the Orchid Center for Laser Surgery in Bombay. So what they have proposed and done is the use of laser in a palliative setting, advanced tongue cancers, where they have used the laser for debulking the tumor. So debulking as in they have just inserted the laser fiber into the substance of the tumor, allowed it to act. They have monitored whether the tumor has been completely devascularized using ultrasound. So once it gets devascularized, it appears hyperechogenic on the ultrasound. So this has been like their endpoint to stop laserizing. They have not removed it. They have not excised it. They have just laserized it, and they've just left it be, like let it be. And over the next 2 to 3 weeks, this mass has separated spontaneously from the normal residual tongue. They have said that there was a marked increase in the lifespan and in the quality of life of these patients. So these were patients who were termed to be palliative because of the volume of the lesion. Either it was involving the entire anterior third tongue or going up to the base tongue. These were tumors which were deemed to be unresectable by conventional methods, as in with margins and all that. So rather than just putting them on OMC or on just like best supportive care, what they've done is they have laserized the tumor bulk and they have given the patient palliative chemotherapy, the TPF regimen, which is like generally cisplatin, uracil, and some taxane, like docetaxel, etc. They have said that the average survival was 8 months, with some patients even living up to 3 years, and the quality of life was well preserved, which is also important in such patients because they live quite miserably. They will not be able to eat. They will many times end up managing with a Rayleigh tube. Many of them will need a tracheostomy and they will have a painful death, like bleed to death. It's quite sad. So if you're able to preserve the quality of life, it is something that you have achieved. Just two pictures that I borrowed from the same paper. So as you can see on the left side, that was the tumor mass. You can see it's involving almost the entire anterior two-third tongue on both sides. And that was an image taken 8 months later when the patient has come for follow-up. It's quite amazing what this paper has proposed. Okay, so the last section of this talk is going to be on the application of lasers in laryngeal lesions and cancer. So, what is early glottic cancer? Let us first define that, because the application of laser is generally restricted to early glottic cancer. So that means lesions which are in situ going up to T2, generally squamous cell carcinomas, and where the vocal cord mobility is still maintained. The cords are still moving. So generally, until this era of the laser-assisted minimally invasive excisions of early glottic lesions came in, the accepted standard treatment modalities were either radiotherapy or open partial laryngectomies. Okay, if you look at history, the first transoral excision of a glottic tumor was done by Bernard Frankel, who used a mirror to excise it intraorally. And then came in the development of the direct laryngoscope and the suspension laryngoscope systems by Robert Lynch, and then came in the first en bloc resection of glottic cancer. Then Jaco Strong and Vaughan brought in the idea of coupling the carbon dioxide laser to the microscope, and so started the era of minimally invasive resection of early glottic cancer. And this was further popularized by Steiner. Okay, so what would you call an ideal treatment for an early glottic cancer? You have to understand that there's lesions inside the vocal cord. You can't even see it by just asking the patient to open the mouth. You need to put in a mirror, or you need to put an endoscope to be even able to see it. So previously, as we were saying, you were open partial surgeries. You were opening up the neck, you're going and removing the tumor and closing it and coming back in. So that kind of an approach would definitely have associated morbidity. So if you want to avoid that, you still want to offer the same cure rate as that was offering until then. You want to preserve the voice. An open partial laryngectomy will definitely mess up the voice of the patient, and it has to be a single stage procedure. This is an advantage over radiotherapy, where although it is non-invasive, it happens over a period of 6 to 8 weeks. And with open partial surgeries, you have to be hospitalized. You have to be in the hospital, and a very high chance of a tracheostomy. So you want a method which can give you all the pluses of these two treatment modalities, but it can avoid the side effects of both these modalities. So with laser-assisted microlaryngeal excisions, you get the magnified view through the microscope. You also get the precision of the laser beam. And what is your target? You want to remove the tumor with negative margins, with minimal margins, but negative margins. And you want to preserve as much tissue as possible. And when you do this laser-assisted microlaryngeal excisions, the resection is generally bloodless. Most of the 99% of the time, you don't need a tracheostomy, and you can keep the number of days of hospitalization to a minimum. Okay, so having said that, we have said that laser-assisted MLE would be one of the best methods for an approach to a glottic tumor. But you also have to look at which of the glottic tumors would be ideally suited to this approach. So these are T1, T2 tumors, which means they're restricted to one cord, or they're superficially spreading to the other cord. They have not gone full thickness into the cord, which means that the cord mobility is maintained and the subglottic extension has to be minimal. That is very important. And it would be preferable that the anterior commissure is not involved by the tumor, and the posterior extension should definitely not be beyond the vocal process. If it's beyond the vocal process and gone to the arytenoid, it gets fixed and it gets upstaged automatically. So the most important factor in a laser-assisted excision of a laryngeal lesion is adequate exposure. This is the rate limiting step. This is the most important step. If you can achieve adequate exposure of the lesion and you can see it clearly through the microscope, half the surgery is done. After that, removal of the tumor with the laser will be done in a few minutes. So to that end, there was a preoperative assessment protocol which was developed by this group from Brescia, Italy, who are very popular for their carbon dioxide laser-assisted microlaryngeal excisions, led by Cesare Piazzi and Nicolai Peratti. So they have devised this protocol which looked at 11 parameters, which was developed to be able to predict a difficult laryngeal exposure in a patient during operative microlaryngoscopy. So this includes the gap between the incisors, the distance between the mentum to the thyroid, what is the dentition status, how is the mouth opening, how big is the tongue, what is the status of the mandible, is it protruding forward, is it sort of pushed backwards, how is the neck movement of the patient? Has there been any previous neck surgery or radiation? What is the Mallampatti's score, which is used by the anesthetist, and what is the body mass index? What I have marked in bold are those factors which were found to be statistically significant in affecting the laryngeal exposure during surgery. Along with this, they also looked at how was the visualization of the anterior commissure. This is extremely important to microlaryngeal excisions, because you either have to make sure that you have resected the tumor and there is no tumor at the anterior commissure, or if there is anterior commissure involvement, you have to remove it as as fully as possible. So what is a class 0? It is when you can see the anterior commissure without any difficulty, even with a large size laryngoscope. In the general, the Boyce-Jackson position, which is the position generally used for microlaryngeal excisions. Class 1 is when you're still using a large size laryngoscope, but you're giving a little counter pressure. Class 2 is when you need to flex the neck as well. Class 3 is when you can't see it with a large size laryngoscope, which is what we prefer because it gives you more working space. You need to focus your laser through the laryngoscope. You need to put your instruments through the laryngoscope. So if you are able to accommodate a large size laryngoscope and see everything beautifully, that is the best situation for a laser assisted MLA. If that is not possible, then you use a smaller size laryngoscope to be able to visualize and to do the procedure. Class 4 is when it is just not possible to see the anterior commissure. So if it is a class 0, 1 or 2 of anterior commissure visualization and the score based on the previous 11 parameters that we described, if it was less than 6, these were the cases which were ideal for a laser assisted MLA. Okay. If the patient had a score of 9 or even more, 2/3 of such patients were seen to have a difficult laryngeal exposure during surgery. Okay, so in a center which does a large volume of laser-assisted MLEs, this score will be very useful for them to classify the patients and even take a decision about whether to proceed with laser-assisted MLE or not. Okay, so what are the principles that are going to govern your resection when you use a laser-assisted MLE? Just follow the cancer. Make sure that you have removed the entire cancer. It is now accepted that no longer that an en-bloc resection is necessary. You can even incise the tumor to see its depth to make sure that you have not missed any tumor at the depth. And so in this process, you can actually ensure that 3-dimensionally you have removed the entire tumor. Now, debulking of bulky tumors and removing it piecemeal through the laryngoscope has also become an accepted method. Specifically, this has been accepted for photoangiolytic involution for vascular lesions with the KTP laser. Now, although intuitively it makes you think that, if you're going to remove it piecemeal, are you sure you're going to get it out fully? Or, when you're sectioning it, is it going to cause distant mess or rather dissemination of the tumor? Like I mentioned earlier in the talk, this carbon dioxide laser has been found to specifically reduce the risk of dissemination because it seals the cut ends of the lymphatics along with the arteries and veins by its action on the underlying contractile muscle. Okay, so now we've spoken about, wanting to use a laser and where to use a laser. We should also be aware of where you should not use a minimally invasive laser-assisted approach to resection of a glottic cancer. When the tumor is so big, you can't even see it in its entirety through the laryngoscope. Don't do it. When your arytenoids are involved on both sides, don't do it. You have to go for a more aggressive surgery. If the tumor is directly coming into the neck, it's out of the question. Or if the cartilage is involved, it becomes T4 and you have to consider a total laryngectomy. Or when the tumor is, you can see the entire tumor, but it is so big that so much of the functional larynx need to be removed that you know that aspiration is going to result, then don't do it. Okay. Like I was mentioning just a few slides back, before the advent of laser MLE, open partial laryngectomy was one of the standards of care for early glottic and supraglottic cancers. So now it is well established and known that there are certain important advantages that a laser-assisted, minimally invasive microlaryngeal excision has over an open partial laryngectomy is that your glottic reflex gets preserved. You're not manipulating both sides of the glottis and the muscle unnecessarily. So the swallowing gets preserved without aspiration. The need for tracheostomy is a fraction compared to the need for an open partial laryngectomy. The chance of percutaneous fistula is non-existent for laser MLE, but a real possibility in your partial laryngectomies. And the duration of hospital stay. All the laser MLEs I have done, I've discharged on day 1, post-op day 1. But for your partial laryngectomies, you will have to retain them for a longer period. Okay, something similar to a previous slide. This is a paper by the same Peretti Piazza group from Italy, who have described also that although we are very excited and enthusiastic about laser-assisted MLE, we know where to stop. So all of us also need to be aware of the limits of a transoral laser-assisted MLE. Okay, the most controversial applications of transoral laser microsurgery is when you're not able to get adequate exposure, when the anterior commissure is involved in the craniocaudal plane. When it is superficially spreading, you can still use it, but when it is going into the subglottis at the anterior commissure wedge, then you have to think twice, because in such cases, there might actually be cartilage invasion. What you thought was a T2 tumor might actually be a T4 tumor, and you might be compromising on the oncological outcomes. So it's important that you assess this extension pre-op, read your CT with a magnifying glass, or so to say, and be sure that you're dealing with the T2. And if you thought it is a T2 and on table you think it's more than a T2, there's nothing wrong in stopping there if you have consulted the patient before, or consider this resection as a debulking tumor, and please proceed either with radiation or another treatment modality so that you don't compromise on oncological outcomes. Again, if there is involvement of the posterior paraglottic space, the arytenoid is fixed. If there is massive involvement of the pre-epiglottic space, which means it's going to come into the neck, or when there is even minor thyroid cartilage erosion, please think twice before proceeding with the transoral laser surgery. In such cases, you have to contemplate either an open surgery or other non-surgical modalities like radiotherapy or chemoradiotherapy, as the case may be. This is just a picture which I've put, which helps us to understand what is a posterior paraglottic space. On the left side is from a specimen, on the right side is an image. So this is a line which is marked from the tip of the vocal process of the arytenoid to the thyroid cartilage. The region of the paraglottis, which is anterior to it, is the anterior paraglottis, and the region of the paraglottic space, which is posterior to that, is the posterior paraglottic space. So lesions which involve the paraglottic space, as is the case in the image, as you can see, these you can consider for transoral laser microsurgery. But if the lesion is extending beyond that line, then you definitely have to consider other treatment modalities. This was called the magic plane, described by Sacco and others, which came out in the Head Neck Journal in 2018. Okay, so this is what governs the laser-assisted MLE, the European Laryngological Society classification of cordectomies. You have 6 types of cordectomies. Type 1 is subepithelial. You just remove the epithelium of the glottis. Type 2 is when you remove the ligament. So you have the epithelium, you have the vocal ligament, then you have the vocalis muscle. These are the layers of the vocal cord. So type 1, you just remove the epithelium. Type 2, you've removed, including the Reinke space, the ligament. And type 3 is when you have to remove a portion of the vocalis muscle as well. Type 4 is when you remove the entire vocalis muscle, that is the epithelium, the ligament, and the entire muscle up to the level of the thyroid cartilage. So type 5 are all the extended cordectomies, whether you remove the arytenoid, whether you remove the ventricle, or you remove the subglottis. All of these have been described and even done by a few authors in literature, but at least the type 5 cordectomies, you will have to remember that there is a high chance of recurrence. You will need to aggressively follow up the patient or supplement within another treatment modality. Type 6 has been described as a type of cordectomy where you specifically remove just the anterior commissure. Okay, so now we have said that we are going to use laser and remove the tumor. We still want to achieve negative margins. An oncological principle of a negative margin cannot be compromised. But what you can do, what you can understand and do is keep the negative margin minimal. Okay, because the glottis is considered like a watershed region in terms of the embryological development. So the lymphatics from the glottis is very less. So the chance of dissemination is again correspondingly less. Okay, so what you want to achieve is a negative margin, but a minimal negative margin, and preserve as much tissue as oncologically safe. So the current recommendations for a free margin is 0.5 to 2 millimeter. Now, what is the problem with achieving negative margins in a glottic lesion is that the lesion is so small. Sometimes you do piecemeal resection and sometimes you lose control of where the margin was. And sometimes after you have resected, because this vocal, this glottic tissue is elastic, it can shrink. And you definitely have the problem of thermal damage and charring if you have not properly focused the laser. Okay, so how can you improve your margins during laser-assisted MLE? Send the margin for a frozen section. Make sure that it is negative on table itself. Or you can even take biopsies from the wound bed, that is the remaining tissue after the resection, or you use some imaging techniques like narrow band imaging. Why this is important for two reasons. We don't want to go back in and revise a positive margin. Why? Because there is evidence in literature that if you go in for a resurgery for a positive margin, it ends up in unnecessary treatment in 84% of the patients. And another reason is that the glottis can be monitored as an OP basis. You can do an endoscopy. It's a 5-minute procedure, and glottic lesions, at least fortunately, produce symptoms very early on, and you can continue periodic imaging for moderately advanced lesions. Now, the problem, as I said until now, is not a positive margin in the case of a glottic cancer. The problem is if after removing the tumor and you do a wound biopsy, the wound bed biopsy, and that comes positive, that is when you actually have a problem. So this paper, which came out in the European Archives of Otorhinolaryngology in 2018, clearly looked at whether it is the margin status or the wound bed biopsy which is going to affect your survival. They found that the margin status did not affect your local control. It was a positive wound bed biopsy after resection, which was what was going to affect your local control rates. So they recommend doing these wound bed biopsies routinely after you have done a type 1 to type 3 cordectomy, because this will help to identify those patients who are going to need additional treatment. If the wound bed biopsy is positive, please do additional treatment. Either you go in for a repeat surgery or you give radiation, because there is a high chance of recurrence of these patients. And they have also advocated that we follow up these patients rigorously in the first year post surgery, because the chance of recurrence is highest during this period. So yes, now this you could probably call the elephant in the room, where you want to know what is the survival rates between transoral laser microsurgery and radiotherapy. Let us understand that. So this was a meta-analysis which came out in the Journal of Head and Neck Surgery in 2019. They have done a systematic review and meta-analysis looking at the rates of overall survival, disease-specific survival, laryngeal preservation, and local control between carbon dioxide-assisted laser microsurgery and radiotherapy. They found that overall survival, disease-specific survival, and laryngeal preservation was better, was favorable for TLM in T1 glottic cancer over radiotherapy in these three parameters, and that there was no difference in local control between the two modalities of treatment for T1 glottic cancer. The next elephant in the room is what about the functional outcomes? So when it comes to glottis, the functional outcomes is speech and swallowing. Swallowing is never really a problem with TLM. That was a problem of the open partial laryngectomy era. Now, how are the voice outcomes following radiation vis-a-vis transoral laser microsurgery? This was again another systematic review and meta-analysis which came out in 2015 in the Journal of Otorhinolaryngology and Head and Neck Surgery. So they have done, what they have done is they have looked at 18 publications which have given the voice handicap index, which is a subjective questionnaire to be filled in by patients post any treatment for a glottic lesion. And they found that these voice handicap index scores were similar between transoral laser microsurgery and radiotherapy for T1 glottic cancer, and there was no significant difference in functional outcomes between the two treatment types. This was another meta-analysis looking at the same parameter of voice, which came out in the same year in a different journal by a different group. What they have reported is, yes, we also found that the VHI scores are the same. However, they have done an additional analysis called the acoustic voice analysis, and they have found that one particular parameter in that acoustic voice analysis, which is fundamental frequency, this was unfavorable for the laser surgery group. So just two things that we need to understand. The voice handicap index is a subjective evaluation. The patient administers the question to himself or herself, and it gives a score of what is the patient's perception of his voice, his vocal ability, and the impact of the disorder on his emotion. However, this acoustic analysis, which consists of three parameters: fundamental frequency, jitter, and shimmer, this is an objective assessment of the patient's voice. It is non-invasive, and so it gives objective data to the clinicians. So this sort of gives 1 point for laser surgery over radiation in terms of voice outcomes, because it has been found that on acoustic analysis, which is an objective analysis, there was one parameter which was in favor of laser surgery. Okay, so let's come to some Indian data on the same point. So this was a paper which came out in 2003 by Sultan Pradhan and the others. So they have looked at 107 patients who were staged from carcinoma in situ up to T2. So until now, we only looked at T1, mostly T1. So up to T2 underwent transforal laser microsurgery. The larynx preservation rate was 92.5%, and the recurrence-free survival was 84% at 5 years, 78% for 10 years. And the cure rates were comparable to the open partial laryngectomies and radiotherapy. However, they admitted that the voice outcomes were superior to open partial laryngectomy, but definitely slightly inferior to the voice achieved by radiotherapy. But still, it was good. The problem arises only when you compare it. If you take voice as is post laser surgery, it is good. They've also added that you do not think of voice as the only only measure of a functional outcome post-treatment. You have to remember, rather discuss with the patient the other morbidities associated with radiotherapy, which is the duration of treatment associated with radiotherapy. Laser surgery is a single stage. The patient is admitted for 3-4 days and the job is done. With radiotherapy, the patient has to come to the hospital for 6 to 8 weeks. The mucosal reactions post-radiations are real. Xerostomia is real and it is long-term. So these things you have to be considered and have to be discussed with the patient, and not just voice in terms of functional outcomes to decide between radiotherapy and minimally invasive laser MLA. However, they have also cautioned that you have to be careful with lesions at the anterior commissure so that you don't compromise on oncological outcomes. It was interesting that a few years later that the radiotherapy department of the same TMH group came out with their outcomes of voice in early glottic cancer in patients treated with radiotherapy. They said that same T1, T2 glottic cancer, they looked at voice before and after treatment. They said that there was a significant improvement in voice post-treatment. However, they have also admitted that history of smoking, T2 disease, and anterior commissure involvement, along with a larger field of radiation, are going to affect voice outcomes post-radiotherapy. So now I think it leaves the field wide open for everyone to decide regarding voice outcomes, because in T1, I think there is no longer any confusion about or misunderstanding about where TLM stands and where RT stands. But when it comes to T2, both laser and radiotherapy are going to have their own pros and cons. So it is a balance of everything that you need to consider before you take a decision for these patients. So if you were to understand why the voice worsens in a T2 stage, whether it is surgery, whether it is radiotherapy, is because when it's a T2 mass and you have removed it either by radiation or by surgery, there is a loss of bulk of tissue of muscle there. And when there is loss of bulk, there is weakness in the voice or asthenia, and this leads to breathiness of the voice. This asthenia and breathiness are part of the GRBAS score, which is what is used to assess the voice. So let me give you a few pointers on what I have experienced in using laser for laryngeal surgery. I have used both KTP laser and carbon dioxide laser. As has been described in literature, KTP laser we did use as an OPT procedure. We experienced the same problem of ergonomics in using the KTP laser. It was clumsy, difficult for both us and the patient. But an additional problem we faced was when you use the KTP laser for removing lesions in the glottis, there was granulation which formed at the laser site, and it was persistent. We would keep bringing the patient for repeat procedures to remove that granulation, either with laser, without laser, but that was a problem we faced with the KTP laser. So then we started using the carbon dioxide laser for laryngeal lesions. Like I have emphasized in the talk, exposure is key. We spend more than 50% of the time that we spend during that particular surgery in exposure, in using the right laryngoscope for exposure, fixing it, in focusing the microscope through the laryngoscope into the glottis. We have to maintain that focal length. Generally, it's about 30 to 40 centimeters between the lens of the microscope and where your lesion is. So this is what is important. And there is a learning curve to using the carbon dioxide laser. You need to know which setting to use. You need to know whether to use the continuous mode or the super pulse mode. You need to know what size of the laser beam to use, what shape to use. There are 3-4 shapes which are extremely useful when you want to, you decide when you want to use it on the left cord or the right cord, or whether you want to cut one point or whether you want to slice the entire cord. Is extremely useful. There's different shapes. And always start with the lowest power. I generally start with about 5 watts and I increase it if it does not act enough. And I generally infiltrate saline into the Renki space so that the lesion will lift up. You will also know whether the lesion is just involving the epithelium or if it's going deeper. If it's deeper, that portion will not lift up. And generally what we have also experienced because of the shrinking of the tissue is if you cut the margin at one point, it immediately just recoils, and then it's difficult to hold it and cut the other margin. So what we generally do is we superficially mark the margins all around, and then we remove the entire lesion. And we always send the margins for frozen section to be sure. And in all patients, the post-op recovery was always smooth. We never had any fall in saturation or need for re-intubation post-op. We were able to start all patients on oral feeds the same evening. And we were able to discharge all patients the next day with some advice for voice rest and hydration and all that. So I'm just sharing one case that I have dealt with. On the left side is the pre-op image. You can see the lesion in the left vocal cord involving the mid-third of the cord. And this is a small video of the post-surgery wound bed. So I hope you're able to see the left cord. Yeah, you can see that red beam. So that is the laser beam that you will see during surgery. This is a round shape. Okay. See, what you have to understand is you can see it as a clear circle. When it is well focused, you will see it as a clear circle. If it is not well focused, it will look smudgy, like like a bindi, like a dot, and like a big dot. And in that case, it will not cut sharply, and you will have a lot of charring. So when you see the beam itself, you will know whether your laser has been focused on point or not. So that is the end of my presentation. Thank you all for your patient listening. And yes, we can take a couple of questions.
So thank you, Dr. Srikamakshi. Your session was incredibly insightful, and I'm certain our audience found it highly valuable.
I hope so.
And we have received questions from our viewers that we would like you to answer. So there's a first question. Are there any instances where laser therapy is combined with other treatment modalities? And if so, how does this combination enhance patient outcomes?
Okay. See, this question off the top of my mind, I remember what I witnessed during my very short tenure at Tata Memorial Hospital. I was there as an observer. So what they would do is all these early tongue cancers, like T1, T2 tongue cancers, they would be taken to a separate building, which was considered their daycare block. And they would be resected with margins. With a laser, with a carbon dioxide laser, they would resect the tumor with margins, and they would allow it to heal by secondary intention. And the patient would be discharged next day or 2 days later. And for these patients, the neck dissection was done as a staged sitting after like 2 to 3 weeks in the main operating block. Why they did this was because in a high volume center like Tata Memorial Hospital, where they have such a large volume of patients coming in, many times by the time you accommodate the patient for the entire surgery, the disease progresses. So what they would do is for an early lesion, they would immediately address the tumor so that the risk of growth or spread gets addressed at that point, and the remaining part of the neck dissection was done at a later stage. This is one instance of when a laser treatment was combined with a conventional surgery with an electrocautery, as in for neck dissection, and the treatment was done. Another instance I can think of was when we did a resection for a glottic tumor. We thought it was a T1/T2 lesion, but in the end, it turned out to be a T3. So we had to supplement the treatment with radiation. In that case, the patient had a complete oncological treatment at the end of it. So these are two instances I can think of.
Okay. The next question is, how does laser therapy impact quality of life for head and neck cancer survivors compared to other treatment modalities?
Yes. So like I was describing, if you take the example of glottic cancers, when you do an open partial laryngectomy, it will definitely impact the swallowing and the speech for a significant amount of time. The postoperative morbidity is much higher. And another instance, what I have seen for early glottic cancers, which were treated like 2 decades back, During my tenure at Adyar Cancer Institute, we used to have patients who would come for follow-up even 20 years post-treatment for an annual follow-up. I have seen patients who have received radiation for their early clotting cancer 20 years back develop second cancers in the radiation field after 2 decades. This is a well-documented risk of radiation. And I have seen it happen. So there are two advantages: the post-op recovery and the quality of life post-treatment, and the long-term survival in terms of a second primary for patients who are treated with radiation, which I think favor laser surgery.
Thank you, Dr. Srikamakshi, for answering our audience's questions. And also a shout out to our audience from MedSynapse for joining in.